Hi everyone, this is our Spina Bifida case presented to you by myself, Mark, and Hazel. This patient is a 3-year-old girl diagnosed with T12 level spinal bifida and has undergone a ventricular peritoneal shunt placement. Her history includes NICU admission, management of bilateral clubfoot, and current therapy services across multiple disciplines. This includes physical therapy, occupational therapy, and speech language therapy. She presents with absent lower extremity reflexes and mobility challenges, but shows intact upper body strength. Functionally, she requires total assistance for basic ADLs like bathing, and she is non-ambulatory. Due to these impairments, participation in activities that are typical for her age is limited, especially in mobility, toileting, and play without support or equipment. Given her cognitive and physical limitations, assistive tech plays a big role in supporting this patient's function. She's nonverbal and primarily scoots or crawls, so devices like an AAC tablet can provide a voice, while low-tech solutions like adaptive utensils and switch-adapted toys make ADLs and play much more inclusive. Her family's very motivated and open to technology, which makes it feasible to implement solutions across all of her environments, including her home, clinic, and soon preschool.
Our primary mobility recommendation is a pediatric manual wheelchair tailored to her abilities and safety needs. A lightweight frame eases caregiver pushing and may allow self-propulsion in the future. A tilt in space helps her rest, reposition, and relieve pressure without changing her posture. Decreased sensation below T12 increases her pressure injury risk, so a Roho cushion with a tilt in space supports skin protection. An adjustable back adapts as she grows with optional trunk supports and headrests for stability. A pelvic belt and elevating footrest with heel loops ensure safe, supported seating. We would provide trays that support play and learning, storage that keeps supplies handy, and this design maximizes comfort, safety, and participation now and as she grows. This section focuses on robotics and exoskeletons, specifically their role as therapeutic tools for children with mobility impairments. Robotics, like the Locomat, aren't for everyday mobility. They're clinic-based therapy tools. Some of the challenges are that they're expensive, require trained therapists, and need a controlled environment. Some of the benefits include repetitive gait training, improved cardiovascular endurance, bone density, and joint range of motion. They can also help with posture and reduce complications such as contractures or scoliosis. The use requires medical clearance and the child must meet minimum height and weight. For our patient, robotic gait training could complement her wheelchair mobility plan as part of a structured therapy program, but is not a substitute for daily mobility. We're also exploring virtual reality and wearable tech to support therapy and engagement. Some of the potential benefits are that game-based therapy boosts motivation, provides measurable outcomes, can be done seated, and supports upper extremity coordination. Fit and sensory overload are possible challenges. Devices must be age-appropriate, comfortable, and safe. Now, the VR options include MetaQuest, PlayStation, Xbox, and spatial training with Go Baby Go. There's wearable tech like Fitbit's Ace 3, which can track upper extremity activity. These tools add variety, measurable progress tracking, and can make therapy fun.
To support mobility and development at home, we recommended 2 ORCHA applications. The first one is Baby Sparks, which offers short, play-based home activities tailored to age and ability. Many activities can be adapted for seated or floor-based play, which is ideal given her non-ambulatory status. In addition, these activities target both motor and cognitive skills, therefore helping her build strength, coordination, and attention spans for preschool readiness. Next app recommendation is KinderPass, and this app includes milestone tracking, nutritional tips, and 150 plus lessons from 7 developmental experts. This is especially helpful for caregivers as it offers structured guidance and resources that support her growth in multiple domains, including fine motor skills, self-care routines, and overall health. Both apps are beneficial for daily routines, can be used in her home environment, and complements therapy goals of independency and participation in preschool activities. Now we are going to talk about relevant patient data for tech access. Cognitive status. Since the patient has a mild cognitive delay, technology must use simple visuals, audio prompts, and provide caregiver assistance. The complexity of the tech should align with patient's attention span and developmental level. Home environment. A two-story home may present physical barriers, such as stairs or narrow hallways. Important data includes layout, safety hazards, patient's play area, and adaptive equipment storage space. Caregiver tech literacy. This determines whether the family can manage app-based platforms, telehealth sessions, or sensor-based tools. Training or app walkthroughs may be required. Parent-recorded videos. These are crucial for capturing how their child moves and interacts in their natural space. This may inform therapy progression and equipment fit. Benefits of telehealth. Improved access eliminates the need for frequent travel, which is important for the family as they are in a two-story home with possible patient and tech mobility barriers. Real-time coaching in the child's own play area supports functional, familiar environment practice. Telehealth maintains therapy progress between in-person visits and reinforces motor skills and use of equipment. Telehealth can also give clinicians insight to early identification of changes, such as new motor barriers or equipment barriers. However, with telehealth, there are limitations, the first being internet reliability. Unstable internet connection could disrupt efficient communication between the family and the clinician. It could disrupt video review and limit accurate observation of the child's fine motor skills. Since the child has a short attention span and mild cognitive delay, this may reduce continuous focus during the session. With telehealth, hands-on cueing is limited because there are certain PT techniques for motor facilitation that may still require in-person visits. The family and the PT must use a HIPAA-compliant platform for telehealth to protect the child's personal health data. However, this limits platform flexibility and may cost more than standard options. Lastly, here are our references. Thank you for listening to our case and our presentation.